Hi, welcome to the ARA Ortho Case of the Week. Let's take a little walk down memory lane, show you a case that you may find that is similar to yours or someone that you know. Let's go back to about 20 years ago. I treated this case. I think I did pretty good. We got a good result. Patient cooperation was pretty nice. And I think I've learned a thing or two since then. So let's take a look and see what we did then. So this is my patient when we first met. Early treatment at that moment, mixed dentition. Mixed means just that there's baby teeth, and they're like right here and right here, and alongside permanent teeth. Front teeth are permanent, couple of back teeth are permanent. Same on the bottom, permanent teeth, couple of baby teeth, some canines that are impacted, very narrow arches. You can see how this is well underdeveloped. We normally want to see this line here, the molar closer to the pupil line. So there's some room for improvement here. It comes to mind that if I have crowding and I have narrow arches, if within the physiology and biology of that patient, we can match those, we may just end up with enough room to make things look a little better. So this is what we did. We had a little bit of a deep bite, overlapping teeth here, they can barely fit. So we put some expanders. At this point, the patient was young, of course. Average case at phase 1 treatment is between 7 and 9, about there. So we went and put an expander. And if you can remember, we're going to do a split screen here real quick for you guys. This is where we started. And we're narrow and collapse. And now we're wide, right? And the teeth that used to be able to have to hang over the other one and still not have any space, now they have space after we've aligned them. Of course, this uses more space from here to here than from here to here, of course. So this is the all new space. We created that. When we're growing, the skull hasn't set in, so the sutures, the same areas that are loosely connected as we're growing, especially as we're born, so we can fit to the birth canal, we can manipulate those slightly and, exert some changes. So this is all new growth, all new space. Now we're holding it for about 3 or 4 months while the bone deposits there. And basically, let's see what we did on the bottom. The bottom, we have a different appliance. We don't have that ability to split, but we can certainly, the teeth that are kind of narrow in, we can upright them. So we call this an E-arch, kind of pushing things out. This is a RPE, a rapid palatal expander. The names are not that important. We have now put some upper front braces, like I showed in the previous one. And here we are when we're done with early treatment. We didn't start these days. This was on a year treatment. Usually early treatment is about 9 months in my office at least, maybe 10. So this is the new arch. This is where we started again. And then this is the new arch. Now she's going to start growing the remainder of the permanent teeth right here, on the lower. Now we have this modified shape of the arch, in which you can see clearly that although there's a little bit of crowding, this is not the objective of early treatment, and now this is going to work out. So let's go ahead. This is without the teeth going in on the sides. Once this fills in, those teeth that are going to be growing in right here and right here, this is going to look very nice. So let's take a look and see the progress until that point. So we started 9 months earlier. This is the progress 9 months later. And then we still have the lower hold in the space. And then we're going to let this patient grow. We bring them back usually about a year or 2 later. And this is how the patient looks when we return. And that's the smile. I haven't done braces yet. This is just the growth modification, If we do a split screen with the initial, you can understand quite rapidly what we did here. Now, like I said, the molar is right here in the center of the cornea, or the middle of the corneal line, which is kind of more associated with beauty, whereas here it was somewhere in the white zone here. And then, of course, we're going to work out on the midline. Always important to remember no one's really symmetrical or anything, but it's looking pretty nice. Now, we're going to do braces. She still has a baby tooth there. We're going to make this all function and fit properly. But you can see how what we've done on the bottom, that's totally going to work out. We can do it almost with our eyes closed. This is going to work. Same on the upper. So going forward, eventually we start the patient. I think a few months later, we put braces on. So this is called now the phase 2 of treatment. Phase 1 is early treatment, which is just orthopedic, changing the growth. Ortho is straight, pedo is growth, right? So now we're going to do orthodontic, straighten out the teeth only, or mostly. So we're going to put some braces on. We're going to work at that deep bite. Still, that curvature is too high. We're going to make this fit. A few months later, we take a lot of photos at the office. I like to track the cases, so this is pretty useful, especially going back in a situation like now. So here we are, opening things up. Now we're closing the spaces. It's called a retraction wire. Okay, use that to pull the teeth back. Same here. And let's see what else. Here we are. Now fully retracted. Now we're gonna retracted means that the upper front teeth coming back, they're fitting against the lowers. So there's no overbite or overjet, actually is the term. And now we're gonna let this roll forward. Use some rubber bands. In this case, we have some ramps here. We glue those on to prevent the patient from biting down all the way. Helps to open the bite. Now we're gonna work at the midlines. There you go. Forget that's just an X-ray. And here we are the day we take the braces off. The midlines are within a millimeter of each other. That's normality. No one's teeth are exactly the same width, left or right. And you can tell this is a little earlier in my career. The resolution of the camera is not as high, but the teeth fit like a lock and key in between each other. That's how we want to see it, you know, lock and key relationship. So when you guide on the excursion side to side, you're chewing is appropriate as a balanced bite. And this is how it's looking on the bottom. Then a few months later, we decided to take some retention pictures. The patient wasn't feeling that great that day, unfortunately. But here's settling in, and I guess she had brushed a little too hard there. But this is what we did for this patient. And let's see what we did. So this is the original. And then with the early treatment, and then we took her to here. I think that was a pretty successful adventure that we went on with this patient. And that's what did we learn? We learned that we are able to modify growth. We learned that today. To some extent, you know, we can do magic. When the cases allow it, we like to begin those cases a little earlier, 7, 8, 9. Whether that means that we're going to take out teeth in the end when we're older, 11, 12, 13, it doesn't mean that we're going to take the teeth out or not. It just means that we can make that case better and make things fit better so that the end result is superior, and hopefully it's a treatment where we can keep all the teeth and or have a shorter treatment, but again with a superior result. Any questions you may have, you can forward them here to the office, and we'll be glad to help you out. If you need a consultation or would like to know what we can do for you or your child, the link for the consultation is here in the description. We'll be glad to help you. See you soon.